you can pull into it and get that pressure in the posterior part of that upper trap. You can go through that way with a band like that. And then you can also slip this guy.
Is that good for levator?
Yes, yeah, you can pin that thing down and go through ranges of motion that way. So you can crank it down that way, reach the arm across, put it under a bit of a stretch. You can put it behind your back, work it through that way. You can tack it down on something. And then when you put it on that glenohumeral border, you know sometimes when the supraspinatus is all jammed up, they say 70% of rotator cuff issues are supraspinatus related. So, and then sometimes shoulder elevation gets snagged. So you can put it right on that border and then put your hand on a wall, get a good stretch on it and going cross-body here, and then start working your hand up with support and stretching this way, working all different directions and trying whichever rotation. For me right there feels pretty snagged. And so you can see I'm gently moving into it and moving out of it. I don't believe in static stretching. I don't think it works very well because you want fresh blood to the area as much as possible. Right there, that's where my snag is. And that's my story with stretching. I always want to drift around the joint until I feel the biggest restriction. And then once I find that restriction, I'm going to go over and over and over. So if this was my routine, I'd probably do 30 or 40 reps right at that angle because that's where I found the snag. And then after that, I'll retest all directions and see how it goes. I like to use a band like this because I like a soft end feel. There's nothing worse than just banging up against the end range of a stretch. It's nice to be able to encourage the muscles to let go for the nervous system. So with a loop, I like to put my hand through and keep it open so that you're not gripping and tiring out any of this. That's pointless. So with that being the case, you can step that same side foot back, rotate that arm down. That's assuming that they don't have any kind of impingement. And then once they're at full shoulder flexion, you can start sliding the fingers up the rib cage, and you'll find where that restriction is, because it might be inferior or it might be superior. And once you're in there, it's about repeating that position. And of course, you can use a tool here to get a better grab. In this case, this wouldn't be for scraping. This would be for tacking it down. It's just a stronger material to push. So that's a good one. I like that one a lot. Of course, you guys all know the chest work. The only difference is I like to do various angles and find what angle is most restricted. And then of course, the bicep work, this is one where I don't move the angle much because it's mostly that long head tendon that I'm shooting for. That usually restricts the anterior capsule. So this is a common one, a common need, and I'm going for that stretch right through here. So that's another one of my faves. This one, even though it's bilateral, can be a great decompressor for the mid-back. You grab on here, sit your hips down, straighten your back out, and then it's, yeah, I could feel it just popping everything open already. And then from here, I'll usually rotate back and forth and find, oh, that right side's tighter. So I'll just rep out the right until it gets moving. It's already starting to get easier. Yeah, pretty even now. Double hips width away from the wall. You step that foot out, and then you lean your hip in. You'll notice my spine stays pretty straight. I'm not bending my spine. I'm keeping it straight, but pushing around the hip girdle. So right there is restricted. So that's the angle I'm going to start moving through over and over and over. So that's the basics if you've got no tools with you, and that's a little restricted there. And of course, I'll switch sides and see what the difference is. So it's this rim right between the hip joint and the iliac bone, and you're riding around the rim of the hip, finding whatever tension you've got. And it's just remarkable how quickly that releases the back and how it can restore rotation in the hip. So this is the advanced version of that. So you hike this thing way up towards the top of the femur, you get a strong stretch on it, and then I'm going to put my foot on the side and then lean that hip down. I don't have a big stretch on this. When I'm doing this, typically I'll anchor it to that, walk way out into the room, put a huge stretch on it, and that, in a short time, I can completely release my lower back in like between 1 and 2 minutes. It's another form of traction here. You're pulling your hip joint back, but you can select which hamstring is tightest. If you got this guy tractioning out the hamstring, and everybody knows this probably, I'm out toeing and then leaning into it, so that anchor point pressure is helping me dial in to this lateral hamstring. And then what I'm doing is sitting my hips way down. I should be a little bit higher. So I'm dropping my hip and externally rotating, and that's really pulling on that pathway. So I notice with the traction pull like that, I end up making much faster progress. Yeah, doesn't take as long because you've got assistance in opening it up. And I think all stretches should be decompressive. I shouldn't be jamming into my hamstring. I should be opening the joint in order to stretch it. It's like that gyrotonic concept of the fifth line. There's the primary movement directions, and then the fifth line is a traction direction, because every joint needs enough decompression that it can glide. You don't want it to be stuffed up and just barely able to move. You want to traction it out so there's space in the joints. My view of plantar fasciitis is that it has a lot to do with the calf tension. So of course I would start with calf work. So my favorite is putting people on that, strapping them down, and then working on their foot and ankle. So I'd be cradling their foot as they're in a hamstring stretch and stretching through the different pathways like inversion, eversion, and neutral. So just getting the calf flexible. I'm not showing you that because everybody knows how to stretch calves. But my favorite is if I were stretching my own calf, I'd be putting it up on something and starting in neutral and then working on inversion. See how light I'm just barely helping myself because I want my anterior tib to fire, because that's going to release the opposite pathway, that reciprocal inhibition. So it's more about repping it out and finding, oh, that pathway's stiff, and then hitting that one over and over and over until now it's starting to open up. Now it's moving, and then back to neutral. And that's getting a lot more flexible already. So that's my favorite way of stretching my calf myself. I do the same version on people, but I'll strap them down so that their hips are in neutral while I'm working on them. So that's a precursor to all this stuff, because all this tension here is producing all this reaction here. So don't just work on the foot, work on the big mover that's challenging it. So
if you were on a table without that machine, you'd have the client supine. You could pin the hips down with
let's go through it.
And then just start repping it out.
Yeah, I don't even need to pin the hips down. I can bring them in like this. He's flexible enough. In everything we do, I always think about the flip side. Maybe there's a restriction in the dorsiflexors that are antagonizing the plantar flexors. So that might be worth exploring. Assuming we've fully mobilized his calf, let's get into the plantar fascia part of it. Ideally, I want to be able to work it on a stretch. I can pull his foot back in. You can see how stiff this thing is. It's just bouncing out at you. A lot of people can't handle getting worked on a stretch here because the bottoms of their feet are so sensitive. Let's see if he can take it. You're handling. So I start with super short strokes on this because it's such dense fibrous tissue and it's so hypersensitive. The goal is to first gain their trust, and then their nervous system relaxes and you can get a lot more out of them. So this is a sticky spot right here. I'm taking the pressure off. I'm not pulling as hard because that is really jammed up there. So just starting to warm it up. So the thing is, plantar fasciitis is, and it's an inflammatory condition, of course, that's in the name. So last thing you want to do is hit it hard, because then they'll get up and go, oh my God, ah. So you want to very gently get it moving. So I'm at a 45-degree angle, pulling away from the calcaneus, and now I've got a broader pressure, and I can feel how if I push a little too hard, his foot gets squirmy. So I'm staying just soft enough that I avoid that. And he's letting it go pretty well. And also, the first ray, when it comes up to the big toe right there, that is a critical spot to work right there. Because often that's the source of a lot of pain, especially between the first and second toe. There's such a hard pull on the metatarsal, and then you see that metatarsal phalangeal joint get all puffed up. and arthritic. So that's a pathway that's really worth scraping through. The deal is with plantar fasciitis, one of the things that happens is when it gets extreme, it's like it's shearing the periosteum off of the calcaneus.
Yeah.
So I'm trying to relieve that pressure right at the insertion of the calcaneus. That's the #1 priority, because then that'll take away the whole symptom. So if they can't handle the scraping, you can do the same with your forearm. If you've got them supported, whatever kind of solid pillow you want to use, I want to cradle it, it's easier to handle. And now I'm getting in there with my forearm. So this is easier to take for the hypersensitive people because it's a blunter pressure, a broader pressure, and I'm still able to affect similar change. This time I'm going the opposite direction. Distal like 3 inches of the ulna. So using it like a blade. So there's that direction going up that way, and I can also cradle it this way and go into the foot. So that's another way. So when you see the MTP deformed, it's a joint dysfunction first of all. So that joint is stretched out this way. His is pretty good for the amount of tension he's got going on. I've seen way worse where it's really bouncing out and then this toe tucks under it. Abducts really strong. So you want to stretch it into adduction, and you're internally rotating that first ray. So I'm bringing it down and in that way, downward. So it's going up and it's moving in that way. So this guy, you're flexing, you're internally rotating, and the main thing is it's a joint dysfunction. You're feeling the joint. There it is. I'm searching for it right in there. And I'm grinding it down. I'm getting it mobilized. So I'm gently making passes at that, trying to get it going. So we pre-tested him. It depends on how much it's a joint dysfunction versus how much it's a muscle that's not triggering. And that'll tell you whether or not you can treat it. So in other words, if I can mobilize this joint far enough, and if I can trigger his hallux adductor, you know, that this guy right here, I can get him to open up again. And then he's going to be able to rehab it himself. But I have to get the joint in a functional position first, because that adductor is not going to be able to do anything if the joint is just like that. Let's see if we got anything out of that thing. Try opening it up and see a little bit. Just moving a little and then let it go. And open it up. Ah, it is moving. Good, it's starting to go. The other thing you can do is try and trigger this muscle, get it to work. Go ahead, open up again. There you go. And then let it go. Open up again. There, come on, come on. There it is. And then let it go. It's starting to work. Go for it. There. It's moving now. Okay, let it go. I know, it's like training something that hasn't done anything in a long time. So the tap trigger thing, the fiery trigger, there's also an electrical stim that some PTs use while they have the person open. And then once, bring that other leg up. Once you've got it going, this is called toe wrestling. You try and open the toes into each other. That's the big challenge. So open it that way. You got some, oh, there you go. Oh, that's it. Careful that it's not just internally rotating. Yeah, that it's all with the feet. So when you're at night, when you're watching Sports Center or something, try and toe wrestle. Try and get your big toes to work into each other. And if they're not able to, mobilize this MTP, trigger the adductor hallux, and get this guy moving. And ultimately, yours isn't so bad that it's incorrectable. You should be able to get that moving. And I know that because I've seen a change. It's already moving. Like just now, look at that. It's starting to move. It wasn't moving at all before. So if you get your feet totally even, and your knees even, and your hips even, and you have pillows between your knees, you ultimately want perfect parallel. That's hip joint width. So, and then you just rep this out. You can do a long hold while you're sitting around. And I mean, when people are desk workers, this is one of my favorite things to give them, because I'll have them put a ball between their knees. And I know they're not going to do these deranged positions and twist themselves. And they're getting their hips to remember perfect neutral. And that's based on adductor tension in that position. And when the adductors are really firing and doing their jobs, some of the external rotator tension, hypertonicity will let go, and the imbalances will let go. So this is something that I do routinely to help turn around those unilateral issues. For the hammer toes, you're holding on the metatarsal head, and then stretching through the extensor. So, straight over the top, I'm getting this to move. You okay there?
Yeah, no, there's no pain at all.
Seemed fine with it. So, he didn't have a horrible hammer toe issue. When somebody does, and it's popped way up like this, within a few minutes you can get it flat. And it's just by stretching this thing out. But, of course, it's not going to stick. You're going to have to work the antagonist and get all that open, because the shorter this thing is, the more this thing's going to go that way, and the more dorsiflexed it is, the tighter those tendons are going to be. So first order of business is to get this to neutral. To open that up, you've got this. So like before, this isn't a joint compression. This is a traction of the joint here. I'm tractioning it out and flexing it. So, and then ultimately you'll see these guys loosen up. The take-home version of that, if somebody's flexible enough in the knee, they can go back this way, plug their heel into their butt, and start working different pathways. Like you've got the first ray, the second ray, the third ray. So I'm selecting each toe. The third was nothing for me. The second toe was stiff. So I'm holding right here on the metatarsal head, and I'm stretching it back, and my anchor point is my heel on my butt. So stronger version of that, if the person has enough knee flexibility, that is, you can lean back into it. When I get into it, whoa, the first and second toe are really bad. So what I was just doing is sliding back and forth, and then I could feel it's the first toe. So now I'm getting into that first toe. I'm rocking back into it, and I'm leaning towards that aspect. There's the first, and there's the second. The second toe is really stiff. So I'm just gently rolling in and out of it. So, and then the foot can plantar flex a whole lot easier. So with this, you can go deep into the heel, and then once you've got that plantar fascia locked in, I like to go cross fiber and get it to open up that way, and then you can go, call that latitudinal versus longitudinal. You can go straight down the arch this way, and you can also tack down what we were just talking about. You can bend those metatarsals over it and stretch through those pathways. So that's another way. If you don't have the knee flexibility, you can work through that. And when you're really stiff, that's enough. Just for, I don't know why it is, but I've had a couple really bad acute sciatic issues, and I was able to get them a long way with the tool. Where
You
they
just
were
off the
really,
insertion?
yeah, and also to the origin points too, right along the sacrum. Push down there. I know this isn't your main snag, Scott, but I'm just showing you.
That's good.
So there's this approach this way. I'll go in this way, searching around right there. And this can just do wonders for sensitive sciatic issues. You're putting it in a shortened position, so you're not putting a ton of stretch on it, and then you're just doing a long hold, and the nervous system likes that. You can totally let go. That's a good one. So this is where I can really feel it right there. I'd be repping this out, and you can see how slowly I'm moving, because I don't want to trigger the nerves to fire up. Slight forward lean for the hips, so his shoulders are slightly forward, so I can get back to front a lot easier. And then I usually use a towel, but I want you guys to be able to see it. Right in there. So the reason I'm grabbing his arm is to control his shoulder, so I can lean him in the angle I want him in. And then I'm zeroing in. Right there is where I feel that tension on him. This is a really powerful and super easy approach to do. In other words, be careful not to overdo it.
So you're right at the base of his cranium there?
Yep,
Yeah.
I was working my way up there. Started down by like C5 and worked my way up. If somebody has full, you could see he had full rotation. This is an easy one to do. If they're really limited and they've only got 10 degrees, I wouldn't do this. I do the one that we just covered. So, same thing, clasping the hands, sinking in here. This is another really fast, powerful move. This one you can get even more power on because he's stable, totally stable. This one I don't do as frequently because it's very easy to overdo it. So I would only recommend doing a handful of passes, like say 3 to 5, and then move on to the next spot. Strumming cross fiber across the neck, and then you'll be able to, some of the snag points will highlight themselves. His neck is pretty healthy overall. There it is. There's a spot right there. So I'm going to go right alongside the spine. This is one of my faves. It's a cervical joint mobility deal. So I'm pushing on the transverse processes right here. So, you know, if you went down the center of the spine, you'll feel the spinous process right in that, if you're fully flexed. If you go just past the lateral groove laterally, you'll feel that other bump, the transverse process. That's the one that I'm pushing on. So I'm pushing that transverse process, or you could just feel like you're sinking into the laminal groove, so that transverse process is on the outside of your fingers.
So are you
Can you
pulling
picture it?
out?
Yes.
Or are you going?
You're pulling out just slightly, and then once you've got it, you're pulling up towards the ceiling. So you feel how that's starting to mobilize, pushing the segment. Can you feel it then? Not really, huh? It's very subtle. So this is one way to get gentle joint mobility. Right there. Kind of hard on the hands though. So you can see in this area, this is the, when somebody's hypersensitive, this is a good tool because you can gather up all this tissue and just hang on to it and side bend them. So you know he's most restricted in the opposite direction. But if he were hypersensitive and nervy, then you'd want to gather up all that tissue and get it to relax. Or if you didn't want a change in his range of motion, like you had full range of motion but nerve pain, this is what I would do. Gather it all up as a Feldenkrais approach and hold it. And then work with it for roughly a minute, and you can support your own fingers with your other hand here. This one I think feels great because it unloads that muscle. My finger, okay, say this is the spine, my finger's just on the lateral side of the spine and pushing straight upward. And then I'm gathering this way, and I've got my other hand supporting these fingers so they don't get tired.
Okay.
Yeah. And then I'm side bending them from there. The thing is, it doesn't last unless it's stabilized. So they're gonna have to do an exercise in neutral to strengthen it, so that it sticks. So come up all the way, and I just want to show you a couple of my faves when it comes to those exercises. So one of them is on the edge of a bed. Are you guys familiar with this one? You hang your arms down, and then you just tuck your chin. Some PTs will do the tuck and extend, but I feel like we're always hyperextending. So it's the chin tuck against gravity, and you could do a chin tuck and a diagonal side bend to strengthen, especially in the direction that's most restricted, like his going away from his left. So he's strengthening his right to let his left go. So once that right extensor is strong, this anterior left can let go. So with reciprocal inhibition. So those guys are good ones. And then for people who, when they're driving and they're at a red light, they can always do chin tucks into the pad in their car. Or somebody who's hypersensitive, they can always do chin tucks into a pillow or into their bed this way to strengthen their extensors and stabilize. I like to fully extend in order to get those calf insertions this way. And then I'm feeling around for where it's at its worst. There's a little bit right there on the medial side, just a little through the calf. It's in the middle, dead center.
It's in the middle, okay.
Yeah, it's deeper, and the gastroc is more superficial. Feels to me like that's the worst of it right there. So you can scrape through here, because it's very rough and it's connective tissue. Or I could be
Instant
working
redness.
through this. Yeah. So typically I find way more tendon tension, but nobody had any true knee pain or anything. Usually there's pain associated and strong misalignment, a lot of tissue tension, but she's just feeling some creakiness when it's quiet. So I don't think her knees are really in bad shape. We don't have any good knee samples around here, but I'll show you guys the basics anyway. So of course there's this path. Whoa, do you see how rough that is right there?
Mm-hmm.
That is probably a primary cause because we're always considering the flip side. If there's issues at the base of the patella, it's almost always coming from here because this is trapping the knee
Oh, interesting.
into a compromised position in the front.
And how about the
Often,
top of the patella?
The common quadricep insertion. So I'll roll through this really quick, then I'll show you that. So there's this deal where you're putting a slight stretch on it. She could definitely use this here. So this is one direction I would work on with her.
basically fascial, right?
Yeah, yeah, and tendinous because the soleus tendon, I'm going for that one too. Because
Oh.
that one felt tight to me right there. Feels thick. And then the other one was the biceps femoris. That one feels tight to me on her right there. So I would be moving up and away this way. You know, I'll show you another good approach to that. So turn on your side facing me. So you can get way more out of the IT band. A little past, sometimes it's a little past 90. Yeah, there it is, right there. One fun trick for the IT band with it, it could be scraping or it could be just treating it, could be just pushing on it. Once you get to a certain joint angle, you can feel it way more right there. And you can get more out of it that way. And you can also put it in a more extended position and roll over biceps femoris this way, and that's a really powerful approach. So often the biceps femoris issues come along with the IT band issues. It's just all lateral path stuff. So, and then I'm going on the lateral head of the femur, going over the top of that to get that tendon to stretch, and that's unloading that lateral knee right there. There's all that stuff. Now let's get to what Scott was asking about. Turn over on your back. Hers, I feel more on the vastus lateralis than I do the common insertion right here. Often when there's pain there, I'll fold it up and work on it with my forearm this way. So there's the common insertion here, and then I can go through IT band this way and vastus lateralis. She needs vastus lateralis work right there. So, okay, so we've got all these approaches. There's also, you can, when there's a medial knee pinch, this is a tricky one. If you guys want to try this, quite welcome to. You can grab the, I'm grabbing the tibia, and then it's like I'm using my forearm to peel the femur off of it this way. So this is a joint distraction move right there. That can be a really good one when there's a pinch on the medial meniscus. Pretty easy to do. And then, as far as the patellar tendon issue, a lot of, you okay there?
Yep.
You were folded up for a while. There we go. Now it's there. Let's see. Oh, you've got very good extension. Too much extension. There might be a hamstring. Yeah, there's a little bit of a medial hamstring weakness. Same as that woman I was telling you about. It'd be worth developing that medial hamstring right there. So that like hamstring curl sitting, you know, but
Right.
rotating your leg so it's all the medial hamstring. You don't need this one to tighten up. You need that one to tighten up.
And then that'll bring balance.
That'll stabilize it so
Stabilize
it
it,
doesn't
okay.
buckle in because of this.
Right,
So,
okay.
so there's that, and then this is a really good one for you guys to know. That anterior tib. So I'm going right along the tibia, and I'm using the edge of my palm, and then I'm plantar flexing and inverting her foot.
That was
So-
a plantar flexion
Let's see.
in general.
Point both toes down as far as you can. This one's weaker. It's not as good through the midfoot. So that'd be worth doing. Working through. You can work through here. I mean, you can use a forearm to go through here. This is another scraping opportunity too because it's pretty superficial. And put a stretch on it this way. So it's another way to approach it. And of course, you can scrape all the way through all that stuff. You guys would know that. But this is a really valuable one. There's a few little joint modes too. I'm going to show you guys. She really needs this. If she had an issue in the inferior capsule of the joint, this would be a prime target because this feels really stiff to me. And I would never work on this without really working on the calves because I'm sure it's related to calf tension. And I was going to show you the ankle joint moves. I'm going allofibular joint first, down this way, and then subtalar joint, which she doesn't need. But if she did, you'd feel a restriction here. And once you feel the restriction, you can mobilize it over and over and over. So I'm pushing her into dorsiflexion, and I'm pulling that joint. I'm distracting that joint down and rotating it. And usually you can get this thing moving pretty quick. So hers is really elastic though, so I'm not going to do much of that to her. But good to know.